I would be honored if we don't have time probably today, but to send me any questions or comments or to hear from you. So the next slide, please. Um, just in terms of my disclosures, I received some royalties from various publishing companies. I am currently the editor-in-chief of a journal called Current Psychiatry Reports. I do chair this National Comprehensive Cancer Network Distress Guidelines Panel, and I co-chair with Dr. Luigi Grassi, the World Psychiatric Association section on psychology and palliative care. Next slide. So, why are we talking about this very important topic? Well, there are, in fact, many barriers and issues at the end of life regarding making a psychiatric diagnosis. And so it's important to understand that, but more importantly than the diagnosis probably is just really understanding the symptoms and the treatments that we can provide to patients and families at the end of life. And it's complicated because sometimes, at least in the United States, for example, hospice comes in at the very end, and other providers are really not, like psychiatrists, are not part of the team. So, depending on where you're trained or where you're living or how you're providing such services in the facility or in private practice, etc., this may be a factor in how you are engaging or at what point you're working with patients and families. Next slide, please. So what are the barriers to this? And we'll go one by one. Maybe you can put them all out there, Rainer. Not knowing how, maybe you weren't really trained in how to do this. And I'm speaking to us collectively. It's not really, specific to being a psychiatrist or social worker or psychologist or primary care doctor, but many of us really don't know how to do this. And so there's an assumption that everyone is understandably depressed or anxious. Now, that's not accurate, that assumption, and in fact, there may be other important disorders such as delirium that really supersede the depression or anxiety, or could be combinations. Sometimes we don't want to upset the patient or the family with talking about psychiatric issues at the end of life. And, and of course, we know many reasons for that. Our own discomfort with with um, with the with terminal illness, and it's also there's a lot of time that this takes to sit down adequately with the patient to understand what they think about this, to talk to the family. And there may be family members who aren't present. You may have to do this by phone call or telehealth. And there may not be psychiatrists or other mental health professionals there at the facility or at, where the patient is, so that you don't have a team approach like you may have in other settings. So there are complications and barriers to this. Next slide. So these are additional factors that you can think about when you're seeing a patient. And of course, then there's a big difference between seeing a patient with terminal illness who's perhaps an adolescent versus somebody midlife or at the end of life, or somebody who's had chronic psychiatric condition in the past and who you know. But there are many, many factors that should be taken into account at the end of life. And I want to highlight at the very end the religion and spirituality issues, because many of us don't feel comfortable necessarily talking about religion or spirituality, but these are very important topics for patients at the end of life, and for many patients, not for all patients. In addition, suicide is an important issue. Almost every patient I've ever seen at the end of life has thought about it. So it's important to I wouldn't say normalize it, but help them understand why they may have thought about that or thinking about that. And in many countries, or even parts of the United States, we have assisted suicide, or it's legalized, but and there are rules and issues all about that, and especially in Canada. But so it's complicated where you are, but I find that it's important to raise it. Substance use or is another one, and you really have to find out what patients' thoughts are about taking, for example, cannabis or other medications that might be comforting at the end of life for them. And there are newer agents that we're trying to understand might help patients ease their comfort, but also their pain. Next slide. And I'll try to go through these quickly, but you can see that, many of the issues that we see with depression, and those are the first top on the left, you may see them, but then that may not be really major depression. It may really be due to not eating, not sleeping, and the medications themselves that we may be giving for pain. Patients may be sleeping too much and out of weakness, and might not be able to have a conversation about it. And so bringing in family and close people at the end to help understand where the patient's thoughts and needs might be very, very important. But a lot of times patients get very, very jittery, and how to help deal with that. It may not actually be anxiety, but may be related to sort of the end stage of life. And it takes training and understanding to really understand those differences. Next slide, please. So the three most common disorders that we see are anxiety and depression, and I'll try to focus on those today. Next, please. So anxiety, it's really a complicated, usually it's very complicated, complex, and it's a combination of physical and psychological symptoms. So, you can see those in green below. And and um, and treating it the usual way with psychotherapy or a combination of psychotherapy and pharmacotherapy. It depends on how much time the patient has to incorporate or their cognitive abilities at the end in terms of how talk therapy or supportive therapy uh, can be useful. Next slide. Uh, Large prevalence of anxiety in patients, terminally ill cancer, AIDS patients, and the great variations. So you can see the second one, 0 to 39. That's a very big change. So, these numbers are a little old, but they really have held up because anxiety is really very much present and often goes with depression. So usually patients have a combination of anxiety and mood changes. Next slide, please. So these are lots of different types of anxiety at the end of life, and Bill Breitbart and Harvey Chochinov have been leaders in talking about palliative care and end-of-life issues. And the causes, if you can pull that up, Reiner, I don't know if you can on the...
Sorry, how do you pull
That's
it?
okay. Okay. Yeah, but you can see there are many, many overlapping issues that could be related to the various types of anxiety. And on the left, the DNR, do not resuscitate order. So even having those kinds of conversations with patients and families can be very anxiety provoking. And, the causes could be anything from pain control to metabolic changes to pulmonary emboli, bleeding, etc. Next slide, please. So whether or not to treat or not to treat, you really have to go with how the patient is doing or feeling and how it's impacting on their level of distress. You have to talk to the family. Um, Sometimes giving too much medication may make the patient very sleepy and not able to engage with the family, and that may be very problematic for the family. So talking to the patient's family about the risks and benefits, fall risks with treating anxiety with medication, and what's the impact of behaviorally, what's the impact on patients if you treat or not to treat? So these are complex issues and how you're going to treat, who's in the house, what are the safety ramifications, um, all have to be taken into account, fall risks, etc. So next slide. These are some of the ways we treat pharmacologically. Diazepam, Valium can be given orally or rectally. Neuroleptics, probably the safest, but there's a respiratory concern. Antidepressants are limited because they take a while to have an effect. Opioids will affect breathing and, but are effective with anxiety. So it depends on the setting, how much staffing, if the patient's in hospice or in palliative care, and what's the etiology for the anxiety are all very important. Next slide, please. And of course, non-pharmacological treatment and supportive therapy, having family members around, having behavioral interventions, mindfulness, um, pictures, drawing. We have art therapy, music therapy, but it really depends on cognitive levels and situational where the patient is and how easy it is to get access. Some of what we do now, we do a lot of supportive therapy by internet now, so we can run groups all the way almost till the end of life now, which is good, but you really have to have the technology available to be able to do that and the permission to do that depending on where the patient is and family support to get these things set up. Next slide, please. So depression, you can see DSM-5, lots of different symptoms we know, both somatic and psychological, and so these change at end of life, and how to weigh these in importance. And again, it's not so much getting the right, diagnosis for the billing code, but really how the patient is doing. And sometimes the 2 weeks and 5 or more, you really have to look at this in terms of, what's the best for the patient. But there, sometimes it's really hard to match the DSM with end-of-life care. Next slide, please. So if you take a patients, let's say with stage 4 ovarian cancer and the DSM on the left, you can see the DSM, the symptoms on the right are very much, overlapping with DSM major depression, just the treatment for ovarian cancer on the right. So, there's a cross-hatching, if you will, and you just do your best to try to get this diagnosis so that you can be in a better place to treat and evaluate and treat and do the best you can. Next slide, please. So the risk factors for depression, we know them, but a history of depression, substance use or misuse, alcoholism, physical or impairment or discomfort, controlled pain, lack of family or partner support, and medications that induce depression. And there are many, long lists and lots of textbooks that can cause or contribute to depression at end of life. Next slide, please. And these are some of them. And it really depends if the patient's in palliative care or Hospice, a lot of times the anti-cancer drugs are withheld at the end of life, but they may still be there during the palliative care phase of life. So it just really depends on when we say terminal illness, what stage that patient is in. And next slide. So there are a lot of medical conditions that are associated with depression, metabolic abnormalities, nutritional abnormalities, neurological abnormalities such as strokes or endocrinopathies, low sodium, low potassium, low thyroid. So sometimes the patient may be in a situation that you can't get labs, that they're in a palliative or hospice situation, that you're not going to be able to get these kinds of, you're not going to really know the answer to these questions, but you just do the best you can and work with what you have. Next slide, please. So there are many different types of assessment tools. You can use structured interviews. You can use different screening tools. So you should try to if you're going to work in this area, try to familiarize yourself with which screens would be best to use for the patient population and get good at those screens. You can't be a master at everything, so try to you learn a few of the good screens and how to administer them and have them on your laptop or computer so that you can give it to the patient or the family ahead of time. Most of these are self-reports, but sometimes you can use screens based on data from the family or nurse or visiting nurse that sees the patient. Next slide, please. Depression at end of life, there are different prevalence rates, and it really depends on which group of patient with which disorders at the time that they're being seen. So in general, it's a very high rate, but you can see that it's not every patient who's going to be depressed at the end of life. So again, you shouldn't assume that all patients are anxious or all patients are depressed at the end of life. Next slide, please. Gene Endicott came up with some substitution criteria to think about depression and, terminal illness or end of life. And, again, that's based on experience or how to modify some of the somatic symptoms that you see on the left with, different substitution criteria on the right. But if you do that, it's good to note that and write it down so that you can follow that in patient care, or some other clinician can follow your thinking and how you were describing how the patient was doing. Next slide, please. So there are different screening tools. Harvey Churchinoff has been a leader in this, so you can ask, have you been depressed most of the time for the past 2 weeks? There's a 2-item sort of scale. You can use a visual analog scale or the Beck Depression Inventory. Next slide, please. And these are the sensitivities and specificities for them. So again, nothing's perfect, but if you ask the first 2-item, it's really pretty good. And follow it up. Yeah, have you been depressed? And then you can follow it up. So the goals for management would be helping to improve mood, helping to improve the energy level, appetite, and quality of life, quality of sleep, and reverse some of the neurovegetative problems. Next slide, please. The treatment options would be, at the end of life, psychological or pharmacological. Next slide, please. In the psychological, you want to make sure you understand where the patient and families are at, answer questions that might have, reassure, and you always want to give hope to patients and families, not false hope about when they're going to die, because nobody knows the answer to that, but how we can help provide them for the best care possible, to be with them, to help with suffering, and answer questions. They may have issues about their own children, about family members, and so helping them to problem solve and help them think about coping mechanisms that they might have used in the past that were helpful, and to gear them up to use them again, and reinforce the commitment that you want to stay involved in the patient's care. And if you can't, to be honest about it and talk about who else can be involved in their care. Next slide, please. These are the various individual treatment modalities and group or family ways to help, and these are all dependent on in what stage the patient's at, palliative or end-of-life hospice. But many of these are effective, and not everything works the same for anybody. So you really want to look at what they might be interested in, what's helped in the past, and maybe there needs to be a combination of care or trials to see what might be useful. Next slide, please. In terms of pharmacological treatment for depression, we're using ketamine. We're trying that out more and more now. But the standard antidepressant takes a while. Maybe they're on something already, and maybe you need to increase the dose or lower the dose. Trying psychostimulants sometimes is a good idea, depending on what the patient or the family are interested in. Narcotics or sedatives sometimes are very, very helpful. Next slide, please. In consideration, you really want to know the clinical status. Sometimes you can't get an EKG or the test that you'd normally get to really try things out. So you want to do something that's safe and that's not going to harm the patient. You want to ask about what they've used in the past. You want to ask pharmacists about drug-drug interactions if you're not knowledgeable yourself. You want to ask the family what they want to think about. They may approve of certain kinds of medications, and you have to respect that. Mood stabilizers for bipolar disorder may be initiated depending on how much time you have. Sometimes antipsychotics like quetiapine or Abilify might be useful for patients because they work pretty quickly. Next slide, please. Other options are the usual. Sometimes ECT is very effective. It's because it's quick, and if the patient can get to the hospital, sometimes it's the safest because it's under controlled circumstances. Next slide, please. Suicide risk is a very big factor at end of life, and so it has to be addressed, and you have to look at all these issues. If there's been pre-existing suicide in the patient's history or in the family history, male gender, loss of control. But most patients at the end of life think about this, so you have to address it and talk about it in a compassionate way so that the patient doesn't feel scared and guilty about having had these thoughts. Next slide, please. What you really need to think about is hopelessness as a real modifier for suicide, and address it head on and talk about that with the patient. There's always ways to give hope to patients and families, and not in a false way, but in a way that's meaningful. Next slide, please. Delirium is a very important disorder at the end of life, and sometimes it's missed. If patients have a hypoactive delirium, they're not jittery and active, but it's smoldering, and so you don't want to miss that. Next slide. There's a lot written about delirium at the end of life, but if you can get it in the first 24 to 48 hours, sometimes it's reversible. So you don't want to call this a psychiatric diagnosis. You really want to look for metabolic or other etiologies, medical reasons for delirium. Next slide. These are different ways to denote delirium, but it's the most common neuropsychiatric complication at the end of life. Next slide, please.
Sorry, I missed it.
Yeah, I think you went backwards. You hold on 1 second. Maureen, you can park on the street if you can. And my husband will, still on, bye. It's often underrecognized and misdiagnosed. Next slide, please. And there are many different types of causes for it. It could be direct, central nervous system, next, or indirect. So these are different ways to assess delirium. The Memorial Delirium Rating Scale is terrific, the Confusion Rating Scale, but pick one that you know you can use and assess, and it's depending on if you're at the bedside or if you're in other settings. Next. And pharmacological and non-pharmacological treatment for delirium, you want a next slide. There's a big debate about this at end of life, how aggressive to treat it, but you really want to use a minimally invasive way to do it with simple interventions, again, depending if you're in the hospital or out of the hospital. Next slide, please. And you can use low doses of neuroleptics. Haloperidol is the most common drug. Olanzapine or risperidol have also been used. Next slide. And presence of family, frequent orientation, reversal of metabolic causes like dehydration, well-lit rooms, etc. There's no such thing as ICU delirium. So, you really want to make this a medical diagnosis and try to reverse it if you can, but if not, treat it appropriately. Next slide. And there's controversies about terminal delirium. And I don't think we have time to go into that, but it's an important area for discussion. Next slide. And, ask somebody else to see the patient if you're uncomfortable or don't have experience treating this. Next slide, please. And thank you very much. And I have to run, but I appreciate having the chance to speak with you today. Is that okay, Reiner?
Right, yeah. So the only thing I don't know whether I can ask you